A very good morning and welcome to this special broadcast where we shall be talking about Ebola recovery and response on the part of government, and of course how the public continues to adopt to the Ebola outbreak aftermath. Now, you might also want to understand that last year a lockdown was imposed in the districts of Kasanda and Mubende. This was the epicenter of the latest outbreak of Ebola in the country, and efforts to halt the spread of the disease were very outstanding on the part of the Ministry of Health, and within this time that experts were supposed to put this under control, they actually succeeded. It was one of the case studies of management of a disease as very powerful when it spreads and very quickly when it does, and its handling when it comes to public health management. We have experts in the house this morning who will be helping us understand what is a four-pronged recovery and response plan. We shall use the first segment to understand everything Ebola. People might be thinking because it's done, the outbreak is contained, then we can let our guard down. Absolutely not. We shall also be looking at government's strategic plan and the management of any relapse or an outbreak that could emerge as a result of the remaining pockets of the disease among survivors. Experts say a survivor can stay with the virus for a long time, especially for men within their semen. Now, that is something that is very telling, and experts will be helping us understand that. We shall also look at the recovery plan and also the public awareness, which is evidence-based surveillance. That is what you should look out for. I'm Chris Higenyi, and I'll now introduce my two guests who will be helping us understand the dynamics around Ebola, response, and also recovery. Dr. Moses Ebong is the Principal Medical Officer at the Ministry of Health. Many thanks for joining us this morning.
Oh, thank you very much.
And Dr. Abel Biaruhanga is a Senior Epidemiologist at the Ministry of Health. Many thanks for joining us.
Thank you very much.
I'll begin with the epidemiologist. If you don't mind, we've had Ebola in the state that it is reported in the media. For those that have been unfortunate to be victims or be related to the victims of how to come under contact with them, they have a bad experience. For those that have had through media outlets and other information flow channels, they could perhaps be thinking of something as one that doesn't concern them. What is Ebola? What are the characteristics of its spread? And what are the particular dangers that are still within the country, especially in light of our very latest outbreak that is not more than half a year ago?
Thank you very much, the presenter, and good morning, viewers. Ebola is an infectious disease. Infectious means it can easily be transferred from one person to another. Through touch, even close contact with the person who has that disease. It presents with several signs and symptoms ranging from high-grade fever, vomiting from all parts of the body with blood coming out, cough, flu, among others. So it is in the family of the viruses. Remember, diseases can be grouped into viral diseases, bacterial diseases.
Yeah.
So this is generally a viral disease. Thank you.
Okay. Viral is a bit varied. Yeah. And the average Ugandan could be wondering, are there specific stages where they should be concerned that the less viral diseases and the more viral diseases, and how to respond to them? Does Ebola find itself in the cluster of those that are extremely viral to the extent that any small lapse could lead to a large number of people dying. You might want to just clarify that.
Okay, thank you very much, the presenter once again. So as I have highlighted, Ebola, essentially, it was not a common disease in our communities, especially Uganda here. But when we started coming into contact with animals, eating those animals from our forests, that's how the disease started coming in. So it's not really a common disease the way how we have malaria, but in case we get access to wild animals, then we are likely to get this Ebola. So immediately when one person gets it and gets into contact with other people, a quite number of other friends, colleagues are likely to get the infection or the disease. Thank you.
Dr. Ebom, as a principal medical officer, on the 11th of January, we, as a country, declared the end of the latest outbreak. That was in the 11th of January. According to information that I have here, most deployments in the field ended on the 18th of January. That means there are no practitioners or health experts there who are actively looking for Ebola contacts, right?
Okay, I'll answer that.
Okay.
Ebola was declared in Uganda on the 20th of September 2022. Okay, after a young man of about 24 years fell sick from Madudu sub-county. There's a village called
Madudu is in
Mubende.
Yeah.
So this gentleman fell sick, started feeling unwell around the 11th of September. He went to a nearby clinic, it's called St. Florence. He was treated for malaria. You know the symptoms, as Agri was saying, the symptoms are like for malaria.
Yeah.
It is difficult to separate that this is Ebola, this is malaria, especially at the beginning stages.
At the beginning stage.
Yes.
That is at the fever, high fever.
High fever, vomiting, muscle aches, everything about malaria is the same. So this gentleman was referred after the treatment for malaria. He didn't recover. He went to another medical center. They treated him, and I think he was referred around the 15th to Mubende Regional Referral Hospital, where the health workers felt suspicious and isolated him, admitted and isolated him in a quarantine. That is institutional quarantine. So his samples were taken, the blood was taken on the 17th and sent to UVRI, Uganda Virus Research Institute, Entebbe. So on the 19th, the results comes back when it was positive for Ebola. Okay, Uganda then declared an outbreak on the 20th of September. That is briefly about the story of that case. But prior to that, I think there was suspicious deaths in the villages.
Yeah, I was just going to ask that there were reports of death 3 months to the known outbreak. How was that handled? Was it established that it wasn't, or was Ebola?
There's what we call probable deaths. When somebody died, probable. When somebody dies of a disease, suspected, okay, let's say example of Ebola. Let's take example of Ebola. Somebody dies of a disease, but unfortunately they were not tested, samples were not picked, and they were not tested, and they died without being tested. So health workers think this could have been Ebola. So there were a series of deaths that occurred, and it was captured in our systems as probable deaths. So the first case on the 19th was the beginning. That was the first case, and if we count the 142 people who were confirmed with Ebola, it started from the first one. So yeah.
Okay. So when it comes to fears of re-emergence, which is very natural for experts to plan ahead, because at any one time there could be a lapse in terms of public awareness or how people conduct themselves, and then a resurgency could occur. What are the likely causes of a relapse, especially when it comes to an outbreak like Ebola?
Yeah, as you clearly said at the beginning, we have body fluids. There are specific body fluids in our bodies that harbor Ebola for a long time. Actually, it is like a salvage site. That is in the testes, the semen. Okay, scientists say it can take as long as 1 year when it is still infective. So that's why we have a survivors program running at the moment. There's a survivor clinic in the districts that were affected by Ebola. So somebody who is infected and did not die, the 89 people who did not die, if they are males, we are following them up.
You're actively following them up?
Yeah, every day actually.
Okay, so that is both interesting and a cause for anxiety within the population.
True.
89 of these, how many are male?
Maybe I may not give you the specific number, but I think about half of that. Half of that.
Does the monitoring provide for sensitization on engagement in sexual activity?
Yes, of course. They are monitored, they're counseled, they are talked to, and they are supported in various areas, including material things they are given during their visit to the clinics. They're supposed to be visit to the clinics, I think, weekly? Yeah, every week. You go to the clinic, you are talked to by the health workers, they counsel you. If you have an issue, any other medical problem, it is handled. Any social issues, they are handled from there. Yeah, because we fear if they have sex with their with their counterparts, the females, they transmit the infections.
The likelihood. What is the percentage?
I may not give you the percentage, but there's a case, I think you heard of it. There's somebody who infected a female. Okay? I may not mention the names here, but
you don't have to.
Yeah. So there's somebody who infected. Yeah.
Let me just pick it from what he said.
Okay, yeah, please do.
Thank you very much. So this Ebola also has been in other countries, that is Congo, and also in West African countries, Liberia, Guinea. So the West African Ebola, which spread across 5 countries. So it shows that about 13% of those who were infected, so we are able to transmit the infection to their spouses. So because he has already said this virus can remain in the body fluids for a quite long period of time. So since we know it, in Uganda we have set up those clinics focusing on those survivors. And as I said, there are quite a number of activities going on, psychosocial support, also distribution of condoms to those people, and also to reassure them. And we normally test them routinely to make sure that we get to know whether the virus has gone or not. Thank you.
All right. And then has interaction between these people and animals been halted? Because there's a possibility, for example, in the case of the Democratic Republic of Congo, where it is widely known that interaction between humans and animals is the most probable cause of the outbreaks there. Doesn't that apply to Uganda?
Yes, but of course we cannot say that the disease came from animals. We did not come to that conclusion.
Yeah.
But of course, as we said, in those communities, and what we are going to discuss in our recovery plan, we are going to go back to those communities and make sure we tell them about the dangers of eating those animals or getting close in contact with them.
Could you name the animals?
Dr. Bonkane.
Yes, yes. These are questions the medical people are asking. how comes Ebola Sudan? Because Mubende is not near Congo.
Yep.
Mubende is not a border district.
Mhm.
Okay, how did the first case come to Mubende? Eh? These are questions scientists are asking. So there are studies, people are doing research on that, and I think investigations have been done. The animals, one type of animal that is implicated is are the bats. You know, there are caves. Okay, there are caves in Mubende where people mine. I think gold mining.
Yeah, there's gold mining there.
So these caves contain bats, and people think maybe the first case was that interaction between the bat and human. Maybe somebody could have gotten from there. Another theory is that maybe the first case got from a sexual partner.
Who could have traveled?
Who could have traveled somewhere and came back with Ebola. Like, because 1 year is long, somebody could have traveled somewhere and gotten it and brought it. So I think other animals, in your question, apart from the bats, the gorillas. There are these monkeys.
Gorillas.
I mean, the mountain gorillas. Sorry.
Yeah.
And the monkeys as well.
Monkeys.
Yeah.
Okay. So generally, apes.
Apes
Could be high transmitters.
True.
Okay.
Yeah.
All right. So that means, at this particular moment in time, a relapse is not very possible, according to your estimates.
It is possible, because
enlighten us on that.
It is one of the causes of Ebola. It can relapse, just like TB. You can have TB, then again it comes out later. You test positive and start coughing again, or these other signs of TB. So, like for Ebola, the books have written it that it is possible it can relapse on the same patient. Okay. Because, of course, there is a salvage site in the testes or in the breast for women, so it can still relapse.
So in light of what we now have to move into, the strategic plan and management, could you, Dr. Abel Biarhanga, take us through what it entails, what the Ugandan will be looking out for? Is there intervention that will be reached out they should expect?
Okay, thank you very much for the question. So after the outbreak, of course, it really affected the socio-economic welfare of people in the affected districts. You have already highlighted that there was lockdown. So after declaration of Ebola-free Uganda, so we had, as the Minister of Health, an action after review, where we invited people from the affected districts, sat with them, and we started asking ourselves, where did we go wrong? What was in existence to make sure that we control this Ebola? And out of those gaps, what should we do? So that's how we have come with now an Ebola recovery plan. So Ebola recovery plan entails a quite number of activities which are going to be implemented within 6 months. So one of them is to strengthen surveillance activities up to the community level. So we want to engage even the lower person. In our system, we call them VHTs, Village Health Teams. So they will be helping us to notify to the ministry any person who presents with the signs and symptoms related to Ebola. So we still have our Ebola posters across the country, and where we have the signs and symptoms. That's one. Secondly, you asked about the people who died before we really declared. So we want also to strengthen what we call mortality surveillance.
Mortality surveillance.
Yes, so anyone who dies, either at the facility level or at the community level, we should report, gather that information, and even pick samples from these dead bodies to find out what could have killed this person. Then also we have risk communication and community engagement. Again, we engage the community to make sure that they report anything that is related to. Of course, we are working with implementing partners. Also, the government, we still outsource for support from implementing partners to ensure these activities are moving on. But as we dive into what the government is planning to do, we shall enlight more activities.
Okay.
Thank you.
Dr. Ebong, public health structures in response to an outbreak, not only Ebola, across the country are glaringly wanting. So much so that there is fear within certain circles that if the outbreak had moved or spread out of the central region to other areas of the country, then perhaps we could have had a disaster. The fact that it was controlled was a plus. Now the scenario is, what if it had gone to the other parts of the country? Is the existing structure supportive enough, especially when it comes to rollout of quick intervention in case of an outbreak?
Thank you very much, Chris. I think as a country and as a ministry of health in charge for this, in charge of this country, public health, our public health systems are working.
They are working.
They are working.
Good.
Why do I say they are working? We managed Ebola, though it spread. It came up to Kampala and Jinja and Masaka, but we managed to control. You see Kampala, see the population of Kampala, see the number of people, how people get in contact with each other, especially transport means.
Yeah,
all these.
within the city
We managed to control our public health systems, our surveillance systems, managed to control in Kampala. But if they had spreaded to the rest of the country, we know we are few as public health specialists and epidemiologists and these officials that respond, the RRTs, we know we are few. And that's why at the moment we are building capacities. In the recovery plan, we are going to build capacities in each of the districts to respond to Ebola. Okay? There are people we call RRTs, the rapid response teams. Okay? These are people who are trained to handle epidemics, not only Ebola, but others as well, including COVID, including Rift Valley fever. At the moment, we are responding to Rift Valley. So we have the capacity to contain this. We know at the district level, we have health workers, we have public health specialists. So these people need to be trained, and this is what the ministry is going to do, to train the rapid response teams at the district level and also at the regional level. Okay? Like Mubende region, that is a region, Lera region, Gulu, Mbale, Soroti, all those are regions. In fact, the trainings are starting next week. We at the end of it, we think we shall train about 1,600 health workers as rapid response teams. Is
that, Doctor, I don't know whether you can add to that, is what Dr. Ebong talking about contained in what is described as the institutionalized alert management system? Is that so?
Yeah, it is related.
You could also throw more light on the alert system, management system. So
alert management system, which we are really strengthening in the country, is where it can be virtual, it can be physical. We have an office. We have.
Let's focus on the physical first.
Yeah. So the physical, we have an office like at the Ministry of Health. We have what we call a Public Health Emergency Operational Center. Okay. So we give out toll-free lines to communities. One which is dominant and has been shared widely is 6767. So where we can use even a simple phone, which my mother deep in the village has.
Okay.
Yeah, so we tell them if a person has signs and symptoms related to this disease, just send on that 6767. Immediately, within a few seconds, it will have reached at the center here. So when it reaches at the center, we call back either at the district, at the health facility, then we can respond and find out, is it true, by use of those health workers. So we are going to roll it down to regions, as he was explaining. And so far we have 6 also emergency operational center in the regions. And they are stationed at regional referral hospitals, such that when a case happens in their region, they can respond quickly. Then also we intend to take it further to a district level. So there is a person at the district who shall be receiving those messages, even calls. Then calls directly at a health facility where the message is coming from, or even at a village level. Because remember, I told you we have village health teams who are trained to do that job. So we are doing all of this to make sure that we timely respond to any disease of outbreak prone, or any disease that can be able to expand very quickly into the population. Thank you.
Are we benchmarking? And if that is the case, are we looking at Liberia, Sierra Leone cases and following closely how they were able to roll out a management plan? Dr. Bon?
Yes, I think we are benchmarking from best practices everywhere. And that's why we are bringing in the alert management system, especially at the district level and facility level. Okay, at the center.
Yeah, because just before you continue, I remember Ugandan medics were expatriated to the West African affected areas.
True.
And we were able to coordinate. Where is this team? Has it been the one at the focal point of our own recovery and response plan?
Yes, the teams really supported us. There are people who went to Liberia, who went to West Africa, and responded very well. So these are people who are expert in this field at the moment, whether case management in the ward to attend to the cases of Ebola, whether in the surveillance, whether in a laboratory. So these people were taken to Liberia for that. So we have that team, plus other people who have already been trained. Okay, as I was telling you, we are, I think, among the best as far as response to epidemics are concerned.
Okay, are vaccines part of the plan? Can we talk vaccines now?
Yes.
Ebola vaccine. Do we have an available one, Dr. Biaruhanga? If we don't have, what are the trials that are being undertaken?
Thank you very much. Vaccines, of course, you know, are very, very important in really suppressing the transmission of infectious diseases.
That's right.
Yeah, so unfortunately, for this Ebola Sudan, we did not have the vaccine by the time the country reported the outbreak. So several mechanisms went on, and we developed a concept to bring the vaccine. But by the time vaccines reached the country, I think we had managed to control the outbreak. Yeah, because it was going to be kind of a clinical trial, and it was going to work on these contacts of the cases. So by the time all the vaccines were in the country, we really had, we didn't have cases, and also the contacts had finished their days of follow-up. So I think science is still moving on with these survivors. We cannot just leave vaccine aside. We shall go on to see whether we can develop the vaccine for Ebola Sudan. Thank you.
when you say Ebola Sudan, we didn't have enough time to look at the different viruses. Ebola, the Sudan virus, I've heard of Bundibujo. I've also heard of, is it DRC?
Yeah.
Yes.
Could you just take us through the forms of the viruses that we know?
Okay.
And which one is more virulent?
Yes, as a country, and I think what we have experienced, maybe I give an example as I give the different types.
Please.
We have had 7 outbreaks.
7?
Yes,
Oh,
in this
okay.
country.
Ebola outbreak. I
Yes.
thought virus
No,
strains.
no, the strains are fewer. So out of the 7, I think from year 2000, that killed Dr. Lokia.
Dr. Lokia.
Yes. We have had 7. That was in Gulu, then there was one in Budibuju, then there was one in Luero 2 times, and then now this is the... So 4 of these were Ebola Sudan, okay? 2 were Ebola Congo, Ozahi, and then 1 was Ebola Bundibuju. So there are those 3 types of the Ebola virus that we had: Sudan, Congo, and Bundibuju. The 3 types.
Okay, so for
and as far as the virulence is concerned, I think books have it that Ebola Congo is more virulent than Sudan. In fact, people were saying if we had Ebola Congo, more deaths.
in the latest outbreak.
Yes, more deaths could have happened than this.
So mechanisms already in place to manage the other strains.
Yeah, the good thing with the Ebola Congo is that the viruses the vaccines are
The
there,
vaccines are already there.
available. The unfortunate thing about Ebola Sudan is the time the vaccines, as Birhang has said, the time the vaccines came in the country, there was no another case, so we could not give to anybody because there was no case.
Okay,
in fact, because these vaccines are given to the contacts, assuming you have Ebola. For us, maybe we are your contacts. They give us before we start developing the symptoms. Okay. So it is some kind of ring vaccination. They vaccinate people who are contacts only, not the general population.
Does that mean we have the vaccines stored? Or they've been destroyed?
No, they have not destroyed. I think it is still in the stores, national medical stores. Yeah.
How long can those vaccines last?
You see, as I said, this was going to be a clinical trial, and we may not have the liberty to talk about that vaccine so much. Okay. Yeah. So
the information is limited.
The information is limited.
Talking about research in light of the latest outbreak, especially for purposes of those that might want to deal with another response, has enough research been conducted? Or if there is research that is being conducted, take us through what you are studying. Especially, for example, when it comes to interaction between humans and animals or the birds, especially the bats.
Yes, there is a specific pillar. We have 10 pillars, actually. Okay. Surveillance is one of the pillars. Yeah. Case management is another.
Research.
That's what we call CIRI. Strategic, strategic information, research, innovations. That is a pillar on its own, and there's a pillar lead. So there are other pillars, actually. Community engagement, risk communication, logistics, WASH, continuity of essential services, all these 10, these are pillars. So there's a pillar that is concerned with research.
That is right.
So I know there are several research work going on since the time of the outbreak, and for each of the outbreaks that we have in this country or events, there are researches that are done. So for this, I I might not tell you which research is on at the moment, but it will be presented after their findings.
All right, let's leave that pillar aside and talk about WASH. Is it the WASH that I know? Ensuring that you're clean?
Yeah. So WASH refers to water, sanitation, and hygiene.
Oh, I'm on point.
Yes.
All right, take us through that and how it relates to the average Ugandan out there. How important it is to ensure that you are clean, especially when it comes to sanitation.
Thank you very much. I think over the years, water, sanitation, and hygiene services have greatly improved in this country. And this can be evidenced by our hospital records, where we used to have a lot of diarrheal diseases reported by children, cholera, typhoid, but you can see now they have drastically reduced. So it means that our WASH services have greatly improved. Then also during COVID-19, we also saw an increased trend of using WASH services, hence reducing diarrheal diseases. It has also worked in this Ebola, where we were educating the communities to make sure that we wash our hands, especially at our facility levels, where health workers are dealing with a quite number of patients. We also use hand sanitizers, and which we had also put at all entry points of health facilities in those affected districts. So as he said, we used a quite a number of interventions, including that WASH, to make sure that we control this Ebola, but also other diarrheal diseases. Thank you.
Okay. What are the logistics within this? Because it's massive.
Yeah.
Rolling out a plan and managing it. Execution, implementation, how is it going?
This plan is going to be supported by the government of Uganda with the help of the partners. Okay, we have partners, the WHO, the Baylor, the IOM, and the rest of the partners. They are there. So remember, these partners were supported with some funds for Ebola. And Ebola came to an end very fast. So the funds, I think, remained. So these funds have been repurposed for the recovery plan. Okay, this recovery plan is going to cost us about 120 billion shillings. Okay, so I know the government will provide part of it, and then also the partners, the repurposed money will come from that. So these monies are going to the strategies that Agri talked about, the trainings of the health workers, procurement of equipments, especially maybe lab and other medical equipments, are going to do sensitization, the community engagement, the risk communication to the community. So the logistics are massive. 120 billion is a lot of money.
120 billion Uganda shillings.
Yeah, it's a lot of money. But the funds are already committed as I talk now. The different patterns,
Just maybe to add what you have said.
Okay.
Yeah. We have a system that we go through in as far as logistics is concerned. And also, as you said, we have that pillar. So where we want, we need money, we need supplies. The good thing, vehicles are there.
Excuse me.
The government distributed COVID-19 vehicles in all the districts, the Ministry of Health and regions. So we have vehicles that can help us to do the work. But also we have manpower and also the distribution plan always when we have these outbreaks to make sure that supplies go to facilities where they are needed. So all of these are in place to make sure that we execute our activities. Thank you.
All right. A survivors program. What is that?
Yeah, this is a program for people who have survived from Ebola. Okay, we know people got infected. Unfortunately, others died. About 55 people died.
Yeah.
Out of the 142 people who were confirmed with Ebola, 55 died. So the 89 people are the survivors of Ebola. So these 89 people, there's a program that is ongoing, also being supported by this strategy. I mean, this recovery plan. So there's a survivor program in each of the districts that were affected by Ebola. So there are survivor clinics where the survivors visit every week and get the services. Okay. Yeah. That is
away from psychosocial support. Many of them, their economic livelihoods were disrupted.
True.
Is it part of the plan?
Yeah, it's part of the plan. There is a package for them. In fact, they have even received.
What is it?
Most of them were given money, especially in Mubende and Kasanda. There is an organization called BRAC. BRAC distributed money, about between 300 to 500,000 for each of them, just as a package.
Allow them,
to restart their lives, because there was interruption in their lives. They were isolated from their families, interruption from their livelihoods. So that package was just to bring them to speed.
Has it? Do you have a support mechanism of monitoring and evaluation to that? Because an average Ugandan, if they've suffered and they've been victims, and you give them money, I don't want to say either 300,000 or 500, it could be 5 million, and you give them that money, and you don't monitor how they do their recovery planning, you could end up with people who will still come back to the government saying whatever you gave us is gone, but we are still heavily affected. So you don't mind taking us through that?
Okay, thank you very much. As he has highlighted, this survivors program has a comprehensive package, so including that financial livelihood. So BRAC gave them the money, and also they created an association themselves. Wow. Yes, created an association to ensure that they can rejoin back the community and have where to start from. And through this recovery plan, there is a monitoring framework to ensure that, first of all, we see them getting cured of this disease. Secondly, the other psychosocial or mental disturbance goes off, and also to make sure that they get back to their routine activities to help them really move on with life. So this survivors program is going to take place for more than a year. So we shall see more results coming out to help these survivors. Thank you.
Okay. I have read about a center of excellence in training of personnel to deal with Ebola. We didn't have anything like this before?
A center of, I think a center of excellence is there as I talk now. Yeah, there.
Where is it?
It is in Mubende and Kasanda.
Oh, okay.
Yeah, there were these structures that were built by the partners, the Medicines Sans Frontiers. So those structures, because a lot of money was injected in them, so Ministry of Health wants to turn them into centers of excellence, where people can be trained from there, like the RRTs we are going to train, the rapid response teams. That can be a venue to train them, to do the skills drill, to do other practicals that can enable them acquire the skills to attend to patients and respond to outbreaks effectively. So, yeah, those are the centers of excellence. But before we had them also, Entebbe.
Entebbe.
Yes.
Entebbe and Mulago.
And Mulago, actually.
Okay.
Yes, those are centers of excellence.
So that means when it comes to manpower and personnel, it's a bit disturbing sometimes when there is lack of manpower or the medics to operate some of these centers, yet the medics are very many. I don't know whether the people, this could be a question that could be controversial for you, but the medics in the country right now, away from those that were brought in the fight against Ebola, there were complaints here and there, have they been taken or given these particular tasks? I don't want to say jobs, but these are tasks within the plan to be able to work 24 hours so that the nation can be ready to deal with an outbreak.
Yes, I think that is something that is being strategized at the moment. There are medics who helped us during the response to COVID.
Yeah, those
there are those that have also helped us. Others have come for the second time. Others are new, who came for the response to Ebola. There are plans by the Human Resource Department of the Ministry of Health to absorb them into the mainstream government work. Okay, we know there are a lot of medical workers who are jobless, and this response, in any response, we always involve them because we know they are knowledgeable. They can be trained for a day, and they are up to speed with the rest of the people who are practicing before. So we know there are still human resource gaps in the districts and also at the national level, but I think it is being worked on by the ministry. Yeah.
I see the pillars are 10. So because time is not our very best ally, we shall be going into a break, and when we return, we shall closely look at the rollout of the recovery plan, especially the nitty-gritty that experts see as focal areas when it comes to how the country can fully recover, or even whether we can reach a point where Ebola can effectively be managed and then it's out of our borders. That is something that everyone shall be looking out for. Now, for those who are watching NTV, of course, this very special program is dedicated to Ebola, the post-Ebola recovery plan that is being rolled out by the government. It has a lot of pillars in it, and as we are trying to break down and demystify some of them, we hope you can be able to catch and take note of the critical issues, especially the behavior that needs to be adhered to in order not to lead to a relapse or a re-emergence of the outbreak of Ebola in the country. Let's take a break. We shall be right back. All right, it's now good afternoon, just 2 minutes after the hour of 12, and you are watching the Ebola post-recovery plan talk show here on NTV. I'm Chris Higenyi, and for those that have been with us for the last 1 hour, there's been a whole range of issues that have been tackled in the recovery plan, and of course the experts are with us here in the studio to help us. Let me just reintroduce for the benefit of those that are just coming on board. We have Dr. Moses Ebong, who's a Principal Medical Officer at the Ministry of Health. We are also joined by Dr. Ebel Biaruhanga, a Senior Epidemiologist at the Ministry of Health. Very great perspective and insights into the Ebola outbreak that the country just experienced just over 6 months ago, but also great insights into what is being put together to ensure that there is no resurgence of the disease or any aspects that could be, or rather could lead to an outbreak, especially mismanagement. Now, surveillance is a very critical pillar when it comes to those that are being rolled out in this Ebola post-recovery plan by the stakeholders, including partners including partners like the World Health Organization, Doctors Without Borders, and others that are behind the scenes. Let me begin this second segment of the show by asking about school-based surveillance, because we know that there are fears that if the schools are not well managed, then there could be an outbreak of proportions the nation has never seen on any front, that is any disease, not necessarily Ebola alone. So I'll ask Dr. Ebo Biaruhanga to take us through what the school-based surveillance system is right now and what issues or aspects parents, administrators of schools, and even the learners themselves ought to pay attention to.
Thank you very much, Mr. Igenyi. I remember when we were studying, even at primary level, they were teaching us about hand hygiene.
Yeah.
There's what we used to call 4 F's. And now they're about 6-finger fries, food. Yeah, so sure. We have that basic knowledge about our health. But of course, you know, these diseases, they come from anywhere. And in these recent outbreaks we have had in the country, yeah, we have seen that they have gone into schools and they have really caused chaos. So one, our children, especially in lower schools, yeah, they don't have developed immunity really to fight against most of these infections. So we are coming on board. Of course, it has been there, but we just want to accelerate this surveillance system. We have flu, even currently, most schools, children are reporting flu, cough. So we want all of these signs and symptoms to be reported to our health care system. So we shall use the teachers, we shall use also these children, we shall use the school administrators. Already through the other alert management system we are introducing, just to send a message of 6767. For example, you have a class of about 60 pupils. 20 of them have spent a week without studying. Where are they? Okay?
They've not reported.
They have not reported.
Yeah.
So it means there is a signal something is going wrong. So can we know where these pupils are? That's one. Two, you find that in a class, almost everyone is coughing, okay, which is not good. Of course, some schools also have clinics. Also, the nurses employed should also help us to report a quite number of infections these children are suffering from. So you'll find these children, when they get back home, they find us, we parents at home, even we are stressed. So they transmit the infection to us, and now the infection spreads to the entire population. So this school-based disease surveillance is going to help us to make sure that we reduce these kinds of infection at an early stage. Thank you.
Okay, Dr. Ebong.
Yes.
When Dr. Ebo Biaruhanga spoke about the fact that if students haven't reported for 2 weeks, that means they are somewhere. The school doesn't know, neither do the public health experts, and that could prevent another crisis on its own. I see a relationship between, for example, if there is a lack of information on the death, that is a mortality across the country. Could that be a factor that could exacerbate any crisis if I do not, or if we do not, as experts, Minister of Health and in government, know that at least 50 people died in a particular part of the country because they didn't reach hospitals?
Actually, Chris,
I wanted to put it in the way that, but it's a bit complicated. You know exactly what I'm talking about.
Yes. Now, all deaths in this country actually is supposed to be investigated. As long as you have not died, as long as you have not died from the hospital in the hands of the medics who have diagnosed that you are suffering from a kidney disease, liver, or malaria, or an injury, okay, to any part of the body. If somebody just dies like that,
they drop in the garden.
It must be investigated. That's why the police are involved. A postmortem must be done.
Yeah.
And it must be reported at the sub-county level and a death certificate issued at that level. Or a postmortem done by a qualified pathologist or a doctor. And a diagnosis is made. Then after death certificate can be given. So that is what we call the mortality surveillance.
Mortality surveillance.
Yes, we should know what is killing people.
How does it complicate the recovery, the plan?
Yeah, it is.
Or it's something that is already covered in there?
No, it is in the plan. Mortality surveillance is one of the surveillance methods. You know, surveillance is so robust that the health surveillance, the medical surveillance, is like the surveillance for the military or the police or the intelligence. Okay. Yeah, sometimes ours is also like that. You guys
are helping intelligence?
Ours is almost like that. We do intelligence, health surveillance.
All right.
Yeah, to find out what is really causing this. Who was the first person to suffer from this? What were the signs and symptoms that the person suffered from before death? Or what could have happened? Where could the person have gone? Like the first case of COVID, that one of 2019. I mean, is it 2020? 2020 January. So that first case that had flown to the Middle East, was it Dubai?
Yeah.
The guy was from Dubai. So we even investigate where the person was days or weeks prior to the infection or death. So all these are investigated. So surveillance is actually monitoring. You monitor, you investigate. You do epidemiological investigation. Is it linked to anybody? That's why we had even to use the security systems during Ebola. There are people who are very stubborn. The contacts, you're looking for them, they go and hide. So now you have to tap through the phone system of the security to locate which district the guy is or the lady is. And that's what helped. We identified other contacts like that.
All right.
Yeah.
So there was very close working relationship between the medics at the time,
yes,
and the intelligence.
Yes. Other people are stubborn.
All right.
Ugandans, yeah.
So, Mr. Chris, before you leave, before you leave the point, just in addition to what he's saying. So he has already indicated that every death should be reported.
Should be reported, yeah.
And also should be investigated. Now, to our health perspective, we really want to know what has killed this person. Because we think that in the communities there, if people are dying and are just buried, a relative dies and we just bury, that's where we are likely to get all these outbreaks of, for example, Ebola. So we want to again strengthen this system to make sure that even at the village level, when someone dies, before burying, can we take off a sample and take it to our lab to find out what has killed this person. So it will really help us to know.
Aren't you taking on too much more than you can bite? Because the resources required to factor in the entire country.
No, we already have a system in place. Okay, Chris, we already have a system in place. We are just building on what we already have. Yeah, we already have. We know at health facility there is surveillance going there at health facility level. Okay, health center 2, health center 3, because we get daily and weekly reports from these facilities. Actually, weekly reports from the districts, the facilities.
Okay.
So these ones of schools will add in, these ones of the community will add in. So the whole program of surveillance can be across
All right.
all levels. Yeah.
Let's now transition into a laboratory and the structures in place right now. In previous outbreaks, there has been concern about the amount of time taken to understand whether somebody actually suffers the disease. We've taken samples to Entebbe, we are told, and then everyone waits with bated breath whether this sample is actually positive or negative. Does the recovery plan have or set out how time is going to be narrowed down so that results are known as early as possible, so that action and implementation of whatever needs to be done is also rolled out in a timely manner?
By the Minister of Health has already worked on that. We were sending previously, all along, we were sending samples, whether from Arua or from the farthest place to Entebbe or CPHL, okay, in Luzira here. So that's why we had to bring in the mobile lab system, okay, as a ministry. At the moment, testing was being done from Mubende, okay? All those districts that are neighboring Mubende or near Mubende, that side, samples will be taken. So the turnaround time reduced from 48 hours, okay, to about 6 to 7 hours only. So in case the sample is taken from me, at this time, this is midday, I expect the results by the end of the day, today, okay? So the turnaround time was already done with, was reduced. So in the recovery plan, we want to strengthen this. And the ministry is planning to, it is in the strategic plan actually, to have regional labs at that capacity of UVRI or CPHL, okay? Those mobile labs.
How many regions?
You know, there's the west, there's the east, there's the south.
When you talk about health, the regions might vary. You could be looking at 15 regions within the context of the Ministry of Health. Not necessarily just like we have regional referral hospitals.
No, just to add to what I had said. So all of these regional referral hospitals, have the laboratories. And as he has said, all of these regional referral hospitals, we are strengthening the capacity of the laboratories there. We are not looking at Ebola only. Okay? There are other hemorrhagic fevers, Rift Valley fever, Kulimia Mkongo fever, even cholera. So we want these other kind of diseases that are prone to outbreaks. I've already given an example of cholera. Can be detected at a regional level. Okay? So where we don't need to transport the sample. That's one. Secondly, we already have a robust system, a laboratory robust system, where we use hub. We call it a hub system. So we have hub riders and also the vehicles which pick samples across the country. So, of course, during outbreaks, there is a lot of pressure. There is a lot of pressure. That's why the turnaround time becomes a problem. But already has mentioned that in the case of Mubende, we brought to the lab closer. So there was a mobile lab clinic at Mubende, which helped us to really reduce the turnaround time. Thank you.
Maybe Chris, this recovery plan is not going to support, let me say, the whole country fully, the health systems or what, because it's a
pilot
small
project.
Yeah, it's a small program actually. But our primary target is the Ebola affected districts. Okay, though other activities will go throughout the country, but our primary target is what?
Ebola affected.
These Ebola affected regions. So even the lab, in the plan, it will support the Ebola affected regions.
And how many districts are these?
These are 9 districts.
Name them, please.
So there is Mubende, Kasanda, Kagadi, Jinja, Masaka, Kampala, Wakiso. I don't know if
Chegegwa.
And Chegegwa. Yeah. So those are the districts that had confirmed cases. A confirmed case or cases, actually.
Yeah.
because others had only one case.
All right. Dr. Biaruhanga, take us through case management.
Thank you very much. So case management involves, first of all, a person who has presented with signs and symptoms of any particular disease. Then we take a sample and test that person. If we find is positive, already we have a case management team. He has already mentioned what we call rapid response team. It is a multidisciplinary team which has epidemiologists, it has clinicians, it has people who we call them IPC specialists, infection prevention control specialists. So these who are involved in case management, depending on the infection, of course for these outbreak prone, we normally have an isolation center where they are managed from. Yeah, so these people are trained.
Is the Center of Excellence part of that?
Yeah, that is part of it. So these patients are taken to that, like we are calling it Ebola treatment unit. So our health workers are trained to manage these patients from there. So they are taken through all infection prevention control measures and of course treatment guidelines to make sure that they manage these patients. At the helm of this, of course, you need to protect yourself as a fighter who is the health worker. So when this patient is being managed, of course, we test again this patient to find out whether the infection has gone. So when we find that the disease is over, the patient now is not a patient, is taken back to the community. But taking this person to the community, we need a social worker to be there because we are reintroducing you into the community, which already knows there is a scary disease.
Yeah.
Yeah, so we have to inform the community, this person now is okay, is free of the disease, can get back to the community and do the normal routine work. But there is a lot of work in these, our case management units, because of a lot of scary. I remember during COVID, where it was a case of COVID, really these health workers go through a lot to make sure they manage us. Okay? Yeah, so we make sure that we provide all the necessary personal protective equipment.
Yeah.
So to ensure that our health workers are protected. But also, of course, we make sure that all of these patients are given the required medicines to recover from the disease. Thank you.
Okay.
Maybe
There's something you have to add there?
Yeah, maybe I add in something. Case management, as the name sounds. That is a pillar, by the way.
It's a pillar on its own.
Yeah, it's consisting of doctors, it's consisting of laboratory,
Nurses.
it's consisting of nurses, even midwives, because there are cases that, there are some Ebola cases that are pregnant mothers. So you find somebody delivering in the quarantine, in the institutional quarantine, when they are in the isolation, they go into labor. So even midwives are involved. So as Agri said, it is scary for health workers if they are not trained. We know people have gone to school, people have been trained in medical schools, nurses schools, laboratory training schools, but they need additional training, special training for these outbreaks, especially to manage them in this IPC, infection prevention and control measures. We have seen a lot of casualties of health workers getting Ebola, like this one, 19 of them got infected with Ebola in the whole response. Out of 19, 7 succumbed.
What was the major lapse?
IPC.
IPC.
You just, in this, you have to be extra careful as a health worker, and you must be trained. Sometimes these patients come, like you heard of the doctors in theater who got infected. Yeah. If you are operating on a patient and you don't know that this is a case of Ebola, of course the patient presented with signs of intestinal, acute abdominal symptoms. So the doctors thought it was maybe intestinal obstruction or some other thing. So they were doing exploratory lab, just opening and checking on the organs if everything is okay. If something is wrong, they correct. So in the end, they got infected. All the team in the theater got infected.
That was very unfortunate.
Others died. So the case management, sometimes the health workers, that's why we encourage them, every patient must be treated with care. You must take them like they will infect you with anything.
I am
even malaria.
You talked about breastfeeding mothers.
Yes.
In case a mother is infected with Ebola and she has this infant, how is that managed as a case?
So we encourage the mother to use other methods of
breastfeeding
or feeding.
Or feeding, rather.
Of feeding the baby, because it is also evidence that the breast milk is also a salvage site for the virus.
It can hold the virus.
Yes.
For how long?
Up to 1 year, just like the semen.
Wow. So that means a mother who has contracted Ebola, that is it for breastfeeding.
Yeah, that is it. So we have to support, like that mother, to give alternative feeds to the baby.
Wow. Risk communication and community engagement. What is this pillar? And
hey, those are two pillars.
wait a minute. Risk communication
is a pillar,
and community engagement.
Community engagement is also a pillar.
All right, talk about risk communication. Dr. Ebo will talk about community engagement.
Yeah, risk communication, these are just health messages, like on the screen, as you can see.
Ebola.
Talking about Ebola.
All you need to know.
Yeah, if you go in any health facility, you find Ebola posters on the streets. Even on the border, on the taxi windscreen. Yes.
Reflector jackets.
So all those are health messages. The risks, the health risks, they talk about the health risks that the community should practice, actually, should avoid getting into those risks in order to prevent the disease. So risk communication, you communicate, as the name says, right. Communicating to people, either via media, via print media, or on air like this, or on the radios.
So right now we are undertaking
we are doing risk communication. Yes, this is risk communication.
That is right.
Yes.
Have you been able to measure it? How effective has it been, especially within this period, ever since the outbreak was declared?
It is very effective, especially when it is combined. We know there are people who might not be watching at the moment because people are in offices.
Yeah, that's right.
There are people, so it should be combined, actually. We can do TV, we can do radio, we can do even print. Get opportunity, like in a burial place, we talk about the health risks. We get opportunity in the market. We talk
you
about
ask to address the mourners.
Yes, you can be given a slot. When I was a DHO somewhere, those were the strategies we do, because we would go for burials. Getting that opportunity during the COVID time was not easy. So you talk to the people who are there.
Dr. Berhand, yes. Community engagement.
Thank you very much. Risk communication now drives us to
community engagement.
Community engagement.
Yeah.
So quite a number of people in the communities out there have myth or misconception about these different infections or diseases. Even this recent Ebola. I remember when we were in Mubende and Kagadi. So the community was saying, no, you have just come here to eat money. There's no disease. So there's a
lot of mistrust.
So you need to change that attitude. So you package the information. So you get people, of course, depending on the kind of the disease. Okay, as he has said, if it is at a burial, you can be given a slot and talk. You can call for community engagement meetings. Okay, look here, hey guys, the disease is going to clear us. Can we follow what the experts are telling us to make sure that we control this infection? Because at times we use what I can call drastic measures, where if we think that you are a risk to the population, we pick you from the community and take you to our institutional quarantine. which is always not easy. So that's why we want to engage the community, get the chairperson LC1, the VHT, the politicians, and all the influential people in that community to make sure that we work together and control the disease in the community. And this approach has helped us to make sure that we control this Ebola among other outbreaks we have had in the country.
Maybe to add on that, to show you that the risk communication and community engagement pillars worked. Do you know the minister on several occasions was in the field, in the villages, in those districts, Mubende and Kasanda. And it helped a lot. They changed the trend of things. If the whole minister can come to our village, can come to our district every week, there must be something wrong. So the RDC, you find the RDC in the villages. She's on air talking about the same. So it changed people's mindset.
Tell me, let's stay on mindset change. The president, in one of his very many speeches on Ebola, spoke about the fact that traditional healers were taking advantage. And many people believe that either it was a case of being bewitched, and then they quickly ran to these traditional healers. At some point, these gentlemen and women, I think they also became focal to the whole rollout of the intervention against, especially when it came to contact tracing. Is that away from being on helping, on contact tracing, they needed to be told not to administer medicine. How did that roll out? You want them to help, you're taking business away from them.
I think I was in Luero.
Yes.
Looking for the weak doctor. Who
traditional healers.
I mean, yeah, traditional. Let me say, that's a better word. Traditional healer. We were looking for the traditional healer for 5 weeks. Yeah, we were in Luero, Nakasongola, and Nakaseke during that time of the outbreak. So we're looking for these because our investigation and surveillance indicated that the contact went through Luero to Kampala. So we were in a shrine. So we were looking for the traditional healer. Okay? So because now, if the traditional healer treated this person, then this person must have gotten in contact with very many people, other patients, and also the traditional healer, and also the family of the traditional healer. So we looked for this, and I learned something that these people are in associations. They have associations. The
traditional healers,
yes, and there are very many in their associations. The good thing is their leader was very cooperative with us, and it really helped. So at the time of crisis, like in the response, we don't castigate them for their work. And as you have corrected me, they are not the other way, they are called traditional healers. So, yes, it's good to cooperate with them so that if they see a suspicious case, they can always refer to us. And also to warn them that Ebola doesn't care whether you are a traditional healer or a pastor or what, or a health worker. It kills once you get in contact. So in this case, we had examples of a pastor died, okay? I think, where, Kagadi?
I think Kagadi.
Traditional healers died. Health workers died, you see? So these people should be warned before they get engaged with other patients that are having symptoms.
All right. I think that has been exhausted. Continuity of essential services.
Okay. Thank you very much, Mr. Chris. During outbreaks, let me use, for example, COVID. There is always a destruction of essential healthcare services. One I can bring on board is our mothers going for antenatal care, okay, which is very critical. So, for example, there was a lockdown and these mothers now could not cross. Also, HIV patients.
That's right.
You know, they normally go get the medicine. So this is a pillar that has been actually introduced during this Ebola response to make sure that all of these patients not suffering from Ebola should not die again, because our focus is on Ebola.
Yeah.
And no. So there is a team that will always do that. For example, for HIV patients, we had hub riders, because we already know where they come from.
That's right.
Yeah, so we would drive, and we know you're supposed to come back and get drugs. So we'd find you at home.
In other words, you're saying that if another outbreak is to occur,
Yes.
whoever has to receive the HIV drugs or any other treatment is assured. Explain the structure. How is it going to be?
Thank you very much once again. So we have been saying that as a country, we have our existing structures up to the grassroots level.
That's right.
Of course, with the help of our implementing partners. So we have these people at the community level. We call them drug distributors. So they are linked to our HIV clinics. With the help of, again, our implementing partners, they can get these drugs and take them to these patients. So pregnant mothers also, when there is a lockdown, okay, they are given a liberty to be taken to the facilities. But also, let me use an example of Mubende. So Mubende, you would find that all patients now are running away. That there is Ebola. There is Ebola, everyone who enters Mubende. So through, again, our community engagement, you remember, is very, very key. We would tell the patients, no, it is one unit we are using to treat Ebola. But other departments are still working. That's what we are calling continuity of essential medical care services. So amidst all the outbreaks, other services should continue. Okay, we don't want anyone to die, to get a problem, that because we are responding to one disease. But also, when we are responding to Ebola, we are monitoring even other diseases. Our surveillance system still does that. Because we can be responding to Ebola, and you find another cholera has hit, or any other disease. So we are always on a lookout to ensure that amidst our response, but other services should be given to the population or to patients. Thank you.
Maybe to throw more.
All right, please do
that.
before I ask the question that I wanted to ask.
Okay. Continuity of essential services. You see, during the lockdown of COVID-19, the president would allow pregnant mothers and those who are sick to be taken to hospitals and health centers. So that is part of the continuity of essential services. And we expect, as a ministry, that the health workers will be available to treat other conditions. Okay? They should provide the routine care to patients. And we expect that the national medical stores should have the supplies distributed throughout the country. Though there is what? There is an outbreak, whether Ebola or any other thing. So there must be continuous services to the community.
All right. I think we've exhausted the pillars, right? I now want to ask general information.
Yes.
If a sufferer or a victim of Ebola has gone the 1 year span of time in which they still hold the Ebola virus, especially for the men, in their semen, after that, what happens? Do they suffer? There was something in COVID that was called long COVID.
The effects.
Is there anything like long Ebola?
No, it is not there. What happens is, as Agre said, these people are being tested every time. Especially, I think they test the semen. The semen are taken at intervals of time.
Yeah.
okay, it doesn't necessarily reach 1 year. If somebody turns out negative at 5 months or 6 months after the infection,
then they are late.
They are discharged out of the system. Means they are negative. When they are tested, I think twice, and it is confirmed that they are negative, they are removed out. They are discharged.
Then lastly, of course, the body.
Yeah.
The body is fighting to make sure that all of these viruses get out of the body. As he has explained, it can take 5 months, it can take 1 year, depending on the person. But that's why we are monitoring them to make sure that all of them, by either end of the year or 2 years, the viruses are out of their bodies. Thank you.
The national health system, does it relate to traditional herbal medicine use?
Yes.
Tell us about that, because at the end of it all, if you cannot trace contacts, these contacts can access herbal medicine. Are you trying to put in place a framework that allows for first research on herbal medicine and its application, but most importantly, how the health system accommodates that particular aspect?
In the Ministry of Health, there is a Department of Pharmacy that deals in that. So in pharmacy, they call it complementary medicine. Yes,
complementary medicine.
Yes.
Oh.
So we don't only consider these other ones, the modern ones that are supplied from either joint medical store or national medical stores. Also the herbals. You remember Professor Guang, okay, brought in that herbal medicine of Covidex and became very popular. I think it is still being used up to now.
Yeah.
It is on. I saw them in pharmacies around. So these are very important as well. You know, the development of medicine, this Western medicine that we swallow, either tablets or injectables or what. If you read through, you'll find that they're derived from either plant origin or animal origin or what. So all these are very important in the healthcare system, and that's why they are regarded and licensed by Ministry of Health. We know there are researches that are ongoing as far as those herbal medicines are concerned.
Because most of what we hear is a case of the nation being told, okay, that's fake, that's counterfeit, don't use it.
We have a regulator.
What?
A regulator. National,
body.
I mean, what? NDA.
National Drug Authority.
National Drug Authority. Yes, NDA is the regulator. They know what is counterfeit and what is, especially as far as drugs are concerned. Yeah, because every drug that comes into the country or is being developed, they must test them technically and prove whether they are good for human consumption or not, because some drugs actually destroy your organs and can actually kill.
Is that down to levels of toxicity?
Yes. Yeah, they do tests in these medicines as they come before they are licensed to be sold in Uganda. There are tests and procedures that are supposed to be followed.
Okay. Dr. Abiyaruhanga, you had something that you needed to.
This complementary medicine, as you said, a lot of research has been conducted. Of course, as time goes by, other medicines come on board. But with our traditional healers and whatever, we have a referral system in the country here. So if we normally meet them, we say, if you are unable to manage this patient, please refer to the higher authority of our health facility. Even in private facilities, it is recommended, if you are unable to manage a patient, please refer to a higher authority. But of course, there are some errant either health workers or traditional healers who really want to extort a lot of money from these. So those ones can be dealt with. But there is a system which is clear. Yeah, and we normally, of course, through this risk communication and community engagement, as we have said, of course, we would want these patients to come for modern medicine. Yeah. Because of now the knowledge I attained to make sure that I manage a patient. Yeah, so, but of course, we try to make sure that we tell these patients to go to a facility they know they can get services much better.
Okay. But by the way, the community sometimes they think when they go to a hospital or clinic or where they should be given treatment from there. Part of management of a patient is referral. When you refer a patient, actually you have even managed something that is beyond your capacity, or you don't have the equipments for investigating. Maybe you want to scan, maybe you want to do lab tests or what, and you don't have the facilities. It's better you refer to what? To the next level or to a nearby facility that can offer those services. Part of management of a patient is referring. You explain to them what you are doing and then refer. Okay?
Are refugees included in this plan? Especially those that make the transition during the influx from the Democratic Republic of Congo?
The refugees are included in the plan. There is, if you read it in that plan, there is point of entry, POEs. Yeah, we have points of entry. I think there are about 14. Yeah. About 14, the gazetted ones, points of entry in Uganda. So all these points of entry have health workers. In addition to the rest of the other people that are there, the URA, the security, and the rest. They are also health workers to examine and investigate patients or suspected cases that are crossing the borders, including the animals. Because we know most of the diseases are from animals. Even the animals are examined. Yes.
Actually, I think we just forgot to mention it.
Please do.
So one of the things also we are going to work on is to strengthen border health. Okay? Border health. So as I said, all our designated points of entry, people who are entering should be checked. We are used to customs where URA is doing, but also in our healthcare sector, we are supposed to check them before they enter the country. Also animals, as he has said, and birds. So when they reach in the country, of course, yeah, supposed
chicken,
okay, domestic birds.
Domestic birds. So when they reach in the country, they are in designated places, where we call them refugee settlements. So there is also a structure there by UNHCR. Then also there is Medical Team International and other organizations. But also the government gives a hand. We already have them in our estimated population. And also they contribute to our disease burden. If there is malaria in one of the districts that is hosting refugees, it is part of that. And also we plan with these NGOs to make sure that they attain good health. Thank you.
All right, let's use the remaining 3 minutes to hammer down how Ebola presents to the average Ugandan and what they must do instead of panicking.
Okay. Thank you very much, Chris. Ebola, as I said in the beginning, the presentation is not specific for Ebola. It is a general presentation of infection. When somebody gets infected, whether with malaria or what, there's always a fever. Okay? Ebola presents with a fever as a must. As you see in the case definitions, there must be a fever. So there are other symptoms. Somebody can have joint pains, somebody can vomit, somebody can have diarrhea, somebody can feel fatigued, easy fatigability, somebody can have headache. All these signs are there. And that's why the health workers, and that's where the health workers sometimes mess up, you think it is malaria, you go and feel, is there fever? You
Yeah.
touch the patient without gloves. There, you get exposed. So Ebola presents like that until the last stage, where they are bleeding from the orifices, bleeding from the anal opening, bleeding in the vomiters, bleeding from the eyes, nose, ear, everywhere that is open in your body. So that is the last stage, and from there somebody can die.
Dr. Abel Bjorhanga, wrap this up for us.
Thank you very much, Mr. Chris and viewers. So I end by saying that Ebola, although we are free as a country, but it can come again anytime. So we must be on alert as the community. And if anyone presents with signs and symptoms, which Dr. Ebong has talked about, please report to the nearest health facility or health worker. We shall be able to come and investigate whether it is true or not. So at the government, we are still continuing to strengthen our healthcare system to ensure that such a kind of diseases are detected as early as possible. Thank you very much.
All right. Thank you, Dr. Abel Bjorhanga, a senior epidemiologist at the Ministry of Health. Thank you too, Dr. Moses Ebon, principal medical officer. And thank you, the audience. I hope there's a lot that you have learned. Personally, I'm grappling with the flu. I hope it can get better. But the information shared, of course, should be able to give you an idea of how to deal with the crisis of Ebola, and also have a bird's eye view on what the post-Ebola recovery plan is by the government. That will do it for today. I'm Chris Higenyi. Have yourself a lovely afternoon.